Hello. We are approaching to start the next session, and that will be by Dr. Anchala Kumari. He's done MBBS and MD in biochemistry. He's presently working as senior consultant in charge biochemistry of Dr. Lal Path Labs, Kolkata Reference Lab. She has an experience of 7 years working and reporting in root and special biochemistry. She has done MD from IPGMR Kolkata. She joined DLPL in 2022. She is skilled in clinical biochemistry and immunoassay methodology like CLIA, HPLC, capillary electrophoresis, LCMS, FTIR. She is trained and proficient in IIFT. She is equipped in managing high-volume automated lab. She is trained in internal auditor as per ISO, and is the next speaker. And this topic is autoimmunity in diabetes. So please.
Good morning. I'm thankful to Howrah Diabetic Society for having me on the dais. Myself, Dr. Anchala, and I have joined as a senior consultant, presently working as a senior consultant and lab in charge, Department of Biochemistry in Dr. Lal Path Lab, Kolkata Reference Lab. My journey with Dr. Lal Path had started about 2.5 years back, but Dr. Lal has an epic journey of 75 years. When in 1949, Dr. S.K. Lal led the foundation of Dr. Lal Path Lab. In 2000 and in 2002, Dr. Lal Path attained a landmark of being India's first lab to attain NABL and CAP accreditation. In 2010, we started state-of-art laboratory in Rohini, Delhi. In 2019, a specific department for catering to the genetic department was established, and in 2021 and 22, we started LACE, a program which is dedicated to Autoimmunity Center of Excellence, where we cater to the needs of the diagnostic advances in autoimmune diseases. So autoimmune disease, as we all know, is due to loss of self-tolerance to our own antigen, which lead to the production of antibodies. The T cell reacts against our own antigens, and these antibodies act against and damage our own organs. So the incidence of autoimmunity is about 5 to 7% in the general population, and the incidence it increases with age and is more common in female, because female sex hormones play a preventive role in immunity, in giving immunity. So types of autoimmune diseases, there are two types, organ-specific and systemic, depending on the autoantibodies, whether they are targeting the antigen present in a specific organ or they are targeting multiple organs at one go. So in organ-specific autoimmune diseases, we have, if the target organ is thyroid, we have Hashimoto thyroiditis, Graves' disease. For pancreas, type 1 diabetes. For liver, it's autoimmune hepatitis, and so on. For systemic autoimmune disease, where the autoantibodies are targeting multiple organs at one go, like SLE, rheumatoid arthritis, antiphospholipid syndrome, sclerosis, Sjogren's syndrome, etc. So coming to the main topic, autoimmunity and diabetes. So autoimmunity and diabetes are closely linked, particularly in case of type 1 diabetes. Type 1 diabetes is a result of T-cell mediated destruction of beta cell in genetically predisposed individuals. They target the antigens present in the beta cells, which leads to insulin deficiency, high blood sugar, and dependence on insulin therapy for glucose regulation. So this happens because of the production of multiple autoantibodies, which can target the organs like the cells producing insulin, glutamic acid decarboxylase, zinc transport 8, islet cell antigen, and other pancreatic proteins. Although we all know that type 1 diabetes is most commonly associated with autoimmunity, but in type 2, which is primarily associated with insulin resistance and impaired glucose secretion, still there are researches that has suggested that autoimmune component can contribute to development of type 2 diabetes, like latent autoimmune diabetes in adults and autoimmune positive type 2 diabetes. So latent autoimmune diabetes in adults is often hence known as diabetes type 1.5 because of its late onset, but the causative agent is the autoantibodies. So type of autoimmune diseases are type 1 diabetes, latent autoimmune diabetes in adults, fulminant diabetes, and autoimmune diabetes related with other conditions like thyroiditis and celiac disease. Coming to the diagnosis of autoimmune diabetes, which is like my area of interest. So diagnosis of autoimmune disease, it depends on a combination of clinical presentation, medical history, and laboratory test as well. So clinical presentation and medical history. There will be a typical symptoms like increased thirst and urination, fatigue, weight loss, blood vision, slow healing of cuts and bruises. Age of onset is another indication. So type 1 diabetes develops in children and in young adults, and LADA, that is latent autoimmune disease in adults, develops in adults often more than 30-year-old. On physical examination, we will find the signs of dehydration, weight loss, and skin infections. So coming to the laboratory test, so laboratory test will cater to two areas, one for the diagnosis of diabetes and the other one for the diagnosis of autoantibodies, because the diagnosis of autoantibody and diabetes will lead to the diagnosis of autoimmune diabetes. So for the diagnosis of diabetes, it's well known that blood glucose level is one of the tests. Fasting blood glucose should be more than 126 milligram per dl, OGTT more than 200 milligram per dl. Insulin levels are decreased because mostly it's associated with type 1 diabetes. Hence, insulin levels are decreased, and hence there is also low and undetectable C-peptide levels. Hemoglobin HbA1c elevated in cases of poor glucose control. The autoantibodies, which are mostly commonly associated with autoimmune diabetes, are glutamic acid decarboxylase. Most common is GAD65. Insulinoma-associated antigen 2 antibodies, IA2A, insulin autoantibodies, islet cell antibodies, zinc transport 8 antibodies. So diabetic autoantibody testing. So autoantibodies in the diabetes, as mentioned earlier, is islet cell antibodies, glutamic acid decarboxylase autoantibodies. Commonly done test is GAD65, insulin autoantibodies, zinc transport 8 autoantibodies, and insulinoma associated 2 autoantibodies, IA2A. So the most common autoantibodies are glutamic acid decarboxylase antibody, which target the enzyme glutamic acid decarboxylase. It is prevalent in 70 to 80% of type 1 diabetes, but also in 30 to 50% of latent autoimmune disease in adults. Insulinoma associated 2 antibodies, the target antigens are protein tyrosine phosphatase. It is 50 to 70% common in type 1 diabetes and 20 to 40% in LADA. Islet cell antibodies, they target the antigens present in the islet cell cytoplasm. Their prevalence is 70 to 90% with type 1 diabetes and 40 to 60% with latent autoimmune disease of adults. Zinc transport 8 antibodies, ZN8 protein, 60 to 80% in type 1 diabetes and 30 to 50% in cases of latent autoimmune disease of adults. The other antibodies are insulin autoantibodies, glucagon autoantibodies, and somatostatin and autoantibodies. If we compare all the autoantibodies, then sensitivity of GAD65 and islet cell antibodies is higher than rest of the antibodies. Specificity, if we come to specificity, then all the antibodies are highly specific. They have 90 to 95% specificity. GAD65, other than association with type 1 diabetes and latent autoimmune disease of adults, it's also associated with autoimmune polyendocrinopathy. And insulin autoantibodies are more common in children, whereas GAD65 is more common in adults. So diabetic autoantibody testing helps to identify individuals at risk developing type 1 diabetes and latent autoimmune diabetes in adults. So the individuals at risk in which these tests are indicated are the first degree relatives of type 1 diabetes. They are highly prone to develop type 1 diabetes. So individual with the symptoms suggestive of diabetes, if the patient comes to you and you feel that these patients are a high-risk patient for type 1 diabetes, they become an indication for these testings. If the diagnosis is, LADA diagnosis is there, and in cases where you want to differentiate between type 1 diabetes and type 2 diabetes. Coming to interpretation of the result. So in cases where we are getting positive. So positive, if a single autoantibody is coming positive, it indicates there is an increased risk for type 1 diabetes. Multiple autoantibody testing accelerate means give additive value to the higher risk for developing type 1 diabetes, and high titers of autoantibodies suggest that the disease is going to have a rapid progression for type 1 diabetes. In case of negative results, it doesn't mean that the patient is not diabetic, it only means that the patient's diabetes is not because of autoimmunity. So it may be a non-autoimmune diabetes like type 2. So clinical significance of these tests are that they give you an access to early detection of autoantibodies and can predict type 1 development. Presence of multiple autoantibodies gives you an idea that the disease is going to progress in a rapid scale. And monitoring of autoantibodies can give an idea about the treatment decisions to be taken. So these tests are influenced by various factors. The first one is the age. Autoantibody prevalence decreases with age. Like in children and in younger adults, you will find high titers of autoantibodies. It will decrease later on in the age. Family history, of course, the first degree relatives of the patient will have chances of having a higher titers of autoantibodies. The severity and the presence of the symptoms. The one who is symptomatic and the kind of severity is having will correlate with the autoantibody titer. The blood glucose level, if the hyperglycemia is uncontrolled, the autoantibodies will also be reflected in the test to be higher. So these are the factors that influence the interpretation. Coming to risk stratification, so there are various models and studies which uses these autoantibody titers and helps in risk stratification in the patient. So if a single autoantibody positivity is there, then there is 10 to 30% chances of having 5-year risk of type 1 diabetes. Multiple autoantibody positivity suggests 50 to 90% risk of 5-year risk for type 1 diabetes. And high titer autoantibodies suggest increased risk of rapid progression as said earlier. So summarizing the clinical application, it helps in early detection and intervention. It helps in stratification of preventive trials for the various drugs. It helps in differentiating type 1 diabetes with type 2 diabetes. And it helps in monitoring the disease progression. These tests have some limitations which should be considered. There can be cases of false positive and false negative reporting depending on the kind of platform which is being used, the kind of kits which are being used, calibration controls, and the sensitivity of the reagents. There are variability between the lab reports, one of the common gray areas which we working in lab face. Autoantibodies, persistence, and fluctuation. So there is a temporal variations of autoantibodies, and hence the autoantibody in a particular patient can vary with time. Need for validation and standardization, as most of the kits and the reagents which we use are developed in population other than the population to which we are testing. So there is always a scope for validation and standardization of the test. And of course, any test holds value only when it is giving a correlation with the clinical findings. That is the utmost and the essential part. So diagnosis of autoimmune disease. So diagnostic criteria for autoimmune disease will be two: diagnosis of diabetes and diagnosis of, and there will be immunological criteria. So diabetic criteria, we go with the American Diabetic Association criteria, where the symptoms and the patient should be symptomatic and the random blood glucose level more than 200 milligram per dl, fasting plasma glucose more than 126 milligram per dl, and oral glucose tolerance test more than 200 milligram per dl. Immunological criteria suggest that there should be presence of at least one. More antibodies are good, but at least one antibody, autoantibody, should be present for diagnosing autoimmune diabetes. So differential diagnosis to be considered when you are considering autoimmune diabetes is, of course, type 2 diabetes, maturity onset diabetes of young, secondary diabetes due to pancreatitis or pancreatic surgeries, and other autoimmune disorders like thyroiditis and celiac disease, which may be presenting with diabetes. So to rule out your differential diagnosis, additional tests are needed. These tests are: genetic testing can be done, imaging studies like ultrasound, CT scan, pancreatic function test where glucose tolerance test can be considered. So finally, the diagnostic algorithm for the diagnosis of autoimmune diabetes is, first and foremost, is clinical evaluation and medical history that holds this highest priority. Second is the laboratory test where blood glucose, autoantibodies, and insulin level, which will give an additive value to your diagnosis. They should satisfy two diagnostic criteria. One is the diagnosis of diabetes according to American Diabetic Association, and the other one is immunological criteria, that is, at least one of the antibodies should be present. Then you should consider your differential diagnosis, and then accordingly additional test to be ordered. So in Dr. Lal Path lab, we are doing diabetic autoantibody testing. So we are doing GAD65, that is glutamic acid decarboxylase 65 IgG. The antibody used is IgG. Its biological reference is less than 10 IU per ml. We are also doing insulinoma associated antigen type 2. Its biological reference means it has a cutoff value of 22 unit per ml in a normal patient, normal individual, sorry. Then islet cell antibody, this is being reported through the method indirect immunofluorescence assay. So it's not a quantitative test, it's a qualitative test where we are reporting it in titers as positive and negative. Then insulin autoantibodies, where the biological reference range is 4 to 23 unit per ml. Apart from insulin islet cell antibodies, rest of the tests are being performed by the method CLIA. The zinc transport 8 antibodies, this is performed by EIA. Less than 10 unit per ml is the biological reference interval in normal individual. The slides on. And if only one test of all the tests which I am showing, if only one test has to be ordered, then this is the one where diabetic type 1 autoimmune panel, which is consisting of all the autoantibodies, important autoantibodies for the diagnosis of autoimmune diabetes, that is GAD65, anti-IA2, insulin autoantibodies, islet cell antibodies, ZN8 autoantibodies. This is all the antibodies are being covered in a single panel.
Ma'am, we're running short of time.
So my resources of information were, these are my sources of information. With this, I conclude my topic. Thank you.
Thank you, ma'am.
This is our Kolkata reference lab, and I welcome you all if you would come and visit us.
Thank you, ma'am. Thank you, ma'am, for nice deliberations. It's very deliberate. We are able to know how can we know about the type 1 diabetes. One more question from me, rather. What is the cost of this type 1 profile, rather? This
The test of these costs?
Yes.
Sir, I'll get back to you with the pricing.
Because I think it's costly. It's not.
These tests will be costly, yes. Because the methodology which we are using, these are the costly methodologies, and the reagent and the kits cost is involved. But what is the exact pricing that our salesperson will get back to you?
Okay, the floor is open for the question. Anyone can ask only 2 questions because we are running short of time. So please, if any questions.
So this is located in Newtown.
Newtown?
Very nearby. Please do come.
Anyone?
No,
Any question?
We will be glad to show you the kind of automation we have in our lab. That gives an extra confidence in ordering the test as well.
Ma'am, how do you find GAD65 sensitivity and specificity in diagnosing type 1?
So the sensitivity is like 60 to 70% for the type 1 diabetes and 30 to 40% for LADA. And specificity for all the antibodies which I have said is 90 to 95%. They all are specific.
So, is there any question from the audience? If not, then we can conclude the session.
Okay, thank you. Thank you, ma'am.
Thank you so much, Chairperson. Thank you, Speaker. Ma'am, please stay there. I would like to request Dr. Sukumar Barik to please felicitate our speaker on behalf of Howrah Diabetic Society. Thank you so much.